I'm Mary Fitzgerald. I'm a urogynecologist in Ireland. I have no disclosures and I'm not going to say anything else. I'm just here to introduce the session, which is about pelvic symptoms and treatment of pelvic symptoms in patients who've been through cancer or who may have cancer. And as we live longer and have more cures, we have more patients who have the burden of having had chemotherapy, having had radiation, and having had incredibly life-altering surgeries. I'll just get out of the way and let my qualified team introduce themselves. Each will speak for about 15 minutes, and we'd like the questions to wait till the end, if possible.
Good morning. I'm Gunhilde Buchsbaum from University of Rochester. I have nothing to declare. In the United States, there are currently an estimated 1 million women who have undergone treatment for gynecologic cancer. Approximately 100,000 women are newly diagnosed with one of the gynecologic cancer every year, the majority of these with uterine cancer. You see here the overall 5-year survival rate, and it's very dependent by the type of cancer. However, when detected in an early stage, the survival is uniformly good. 5-year survival above 90%, and many of these women, if there was no spread of disease, can expect a normal life expectancy. Over the last year, as Mayor Pat already mentioned, there has been increased awareness about the need for care of the ongoing health concerns in cancer survivors. Health problems, in part, caused by our cancer treatment. We are realizing that it is insufficient to prolong life without giving consideration to the quality of that life. Further, the Institute of Medicine recognized cancer survivorship as a distinct phase of cancer treatment and recommended development of a plan to improve clinical care and outcomes for cancer survivors. The prevalence of pelvic floor disorders in women who have completed care for gynecologic cancer is high. Approximately half the women experience urinary difficulty, urinary incontinence, sexual dysfunction. Bowel complaints are also high at more than 40%. Dr. Correa will speak later about sexual dysfunction. Radical hysterectomy is known to be associated with a higher rate of complications than other types of hysterectomy. It is thought that the primary cause for pelvic floor dysfunction following radical hysterectomy is due to partial denervation of the autonomic nerve supply to the pelvic viscera, occurring during anterior and posterior dissection, and it is associated with a lateral extent of the parametrial dissection. However, data are scanned and generally based on small numbers of subjects. The study by Ferreira and co-workers compared the prevalence of pelvic floor disorders following radical hysterectomy and radiation treatment in women with early cervical cancer. As you can see, the highest on the list of pelvic floor disorders is urge incontinence and bowel dysfunction. However, there are a plethora of other symptoms, such as voiding dysfunction, stress incontinence, and bladder pain. Stress incontinence here, 30%. Pelvic irradiation is also known to be associated with a high post-treatment associated with pelvic floor disorders. Radiation is thought to cause pelvic floor dysfunction by damaging fibroelastic tissue as well as striated and smooth muscles. In addition, it can cause ovarian failure and result in early menopause, further augmenting the negative effect on pelvic floor function. Some of the data here are again presented from Ferreira. These are the numbers labeled with 1. on the study on cervical cancer. Women receiving radiation treatment, however, were older than those undergoing radical hysterectomy. The study of Erickson, labeled with 2, was evaluating the effect of adjuvant radiation therapy on pelvic floor dysfunction in women with endometrial cancer. Again, highest on the list was urge urinary incontinence, 60 and 80% respectively. However, stress urinary incontinence was common, as is bladder pain. That includes also cystitis and radiation cystitis, and Dr. Crater is going to talk about those a little bit later. We have no good information about the true de novo incidence of pelvic floor disorders following treatment for gynecologic cancers. Most of the evidence is by inference, comparing prevalence of pelvic floor disorders in cancer patients after treatment with controls. In general, the prevalence of pelvic floor disorders is higher in women who have undergone treatment for gynecologic cancer compared to women who have not. As you see here, stress urinary incontinence, cancer survivors 70% compared to 56% in control, fecal incontinence 42% compared to 32% of controls. I did not find any study comparing the prevalence and severity of pelvic floor disorders before and after cancer treatment, which would be the gold standard determining de novo incidence of pelvic floor disorders associated with treatment. We are currently collecting these data at the University of Rochester, comparing pelvic floor disorders at 6 weeks and 1 year following treatment, and compared those to baselines obtained before treatment. And here are our outcomes. At the initial part of the study, we assessed the prevalence of pelvic floor disorders in women presenting with gynecologic cancer. The prevalence that you are seeing here is similar to those reported for women at the same age groups in the general population, which should come at no surprise. We would have predicted that the prevalence is higher for women with uterine cancer compared to ovarian and cervical cancer, since these women share more of the risk factors that we know of pelvic floor disorders. However, this was not the case. When we queried these women about the severity of their symptoms, 1 in 3 rated their symptoms as moderate to severe. Nonetheless, again, to our surprise, the majority of women with gynecologic cancer and pelvic floor disorder of moderate to severe bother declined urogynecologic evaluation, predominantly due to the misconception that such disorders will resolve with cancer treatment, or because of the fear that it might postpone their cancer care. Treatment for cancer, whether surgery, radiation therapy, or chemotherapy, all are associated with collateral damage. That is, damage to otherwise healthy tissue or organs. Recently, there has been increased awareness of this problem. Yet, medical care providers still often consider these issues as part of the usual side effects of cancer care. Oncologists are done with a patient. Primary care physicians do not want to deal with these problems since these are associated with cancer, and specialists often do not get to see these patients. Cancer survivor care centers, the latest buzz, are still at a rudimentary state. There have been limited efforts in proactive intervention. Our urogynecology division has formed alliances with radiation oncology and gynecologic oncology, screening for pelvic floor disorders and facilitating care for men and for women with pelvic floor disorders before and after treatment. We have also performed concomitant surgeries for correction of pelvic organ prolapse and for stress urinary incontinence. There we go. Predominantly in women with early endometrial cancer. A review of these outcomes will be forthcoming. However, we need many more clinical trials in this area. The concept of coordinated care across specialties for cancer patients makes sense, and it is the right thing to do, but it can be difficult to put into action. As I mentioned a few minutes ago about our efforts at the University of Rochester, we have made progress, but we still do not have 100% buy-in. Some of our oncologists opt out. They're too busy to bother with additional tasks. They find it inconvenient to coordinated care, surgical or otherwise, and so on and so on. Patients are unaware that both conditions could potentially be addressed at the same time and are generally not educated with regards to their misconceptions. Further, there are monetary considerations, both on the side of the physician and on the side of the patient. We as physicians should consider this a great opportunity to improve care for patients with pelvic floor disorders before and after treatment for cancer. It should be standard of care to screen women presenting for gynecologic cancer for pelvic floor disorders. We should counsel women about the treatment options, and this should not add stress to patients already worried. To the contrary, in my opinion, this should give hope. There is a future if somebody bothers about the quality of life after cancer treatment. We have to be proactive in providing care for collateral damages that are caused by our treatments. In order to do this, we have to establish strong interdisciplinary collaborations. In short, the prevalence of pelvic floor disorders in women treated for gynecologic cancer is high, and the data are scant. This is a wide open field for investigation and for improving care of patients with cancer and pelvic floor disorders. In order to do this, we have to establish collaborations across specialties. I thank you for your attention.